topics. The first one is going to be by Pedro, by popular demand. That is the cardiovascular risk and lipid management. And it's a very important topic, as we not only need to advise regarding statins, there are other options for patients who are not tolerating statins or are declining statins. And in primary care, we need to show that we are trying to persuade our patients to trial different agents where suitable and possible to improve the cardiovascular risk. So without further ado, Pedro, I'll leave it to you.
Thank you very much, and welcome everyone. My name is Pedro, and I am one of the specialist pharmacists at St. George's Hospital, and I work with cardiovascular disease and lipid disorders. I've had a large QI project that I undertook with the South West London collaborative teams in the past couple of years, and that the project finished in March. And now I'm continuing the role. Today I'm going to do an overview, a whistle-stop tour on cardiovascular management, which includes lipid optimization. I am aware that this area, optimization area, is part of your cholesterol targets for this coffee. So please give me a shout if you've got any questions, or if you can let me know if there's anything in the chat. I'm happy to stop as we go along. Just tell me if these slides are changing as well.
They are.
Okay.
They are.
Okay. So this is a summary of what we're going to cover today. So I'm just going to give us an overview on where we are, the state of play, and the size of products for the cholesterol management. Have a look at some newer lipid lower therapies that are available in the market. Going to go through a bit of statin intolerance management, using some case studies from my clinical practice, and hopefully we can look at also some a patient case on familial hypercholesterolemia and how to manage patients. And I've prepared some slides as well for about the South West London lipid guidance update as well, if you have time, including the referral criteria and so on. Let's get to it. So just tell me if you can see any notes on the side of the slides.
No, Pedro.
Okay. So I like to start this slide because it's always good to give a summary of why why lipid management is as one of the top priorities in the NHS these days. And this started with the NHS long-term plan, where we identified the main biggest areas of the NHS staff and services can improve to prevent cardiovascular disease and cardiovascular events. And the single biggest areas that they've identified was the ABC, which stands for atrial fibrillation, blood pressure, and cholesterol, and diabetes. And high cholesterol is known to have to be associated with a third of all heart attacks and 25% of deaths. And we know that lifestyle changes and diets are very important for lipid management. However, it's normally not sufficient to bring patients to the lipid targets as per national and other international guidelines. And we know that from very large clinical meta-analysis and randomization studies, that every 1 millimole reduction in the LDL, we can reduce the risk of cardiovascular events by 25%. And we know that this lipid optimization should be undertaken as a holistic approach, including other risk factors as well, blood pressure, lifestyle, smoking, and review of adherence to current therapies. We know that statin therapy is adherence is as low as 20% after 5 years of a heart attack. And later on, we're going to talk about FH, which is a genetic disorder affecting 1 in 250 people in the UK, and is associated with high mortality and morbidity if left untreated. And this is just this graph is just a summary of several clinical trials and Mendelian randomization studies showing the correlation between LDL and cardiovascular risk. You can see that the lower the LDL levels, the less is the risk for cardiovascular diseases. You see here in the middle that by reducing 1 millimole per liter of LDL, you have a reduction of cardiovascular disease by roughly 25%. And this reduction is sustained over the years if you continue with the lipid-lowering therapies. The OCL partners have put this size of the price cholesterol optimization tools as part of the large-scale national lipid optimization project, where they show the correlation between optimization of patients with statins and the benefits benefits to cardiovascular reduction and even prevention of deaths over 3 years. So you can see here just a progress last March 23. Statin patients with recorded CVD on statins was around 81%. And with this ambition, if we increase the statin uptake to 86%, this will be correlated with about 156 cardiovascular events avoided, 19 deaths, and a large amount of health associated costs. And this ambition increases as the statin uptake increases as well. Is there any issues? Someone is checking out. Sorry, let me just stop here. Yeah, can everyone hear me properly? Is there any echo, anything? If you can just mute yourselves, please. Maybe that will help with the sound a little bit. I'll try to speak up. And this was just, and that was just an example, but UCL partners have produced this for all ITSs in the UK, and also for size of the price for blood pressure as well. And you can see as the blood pressure management improves, and it's associated with a reduction in heart attacks and deaths as well. And this is another just a little infographic to summarize that the impact of cardiovascular prevention nationwide. As you can see, by preventing cardiovascular events and death, we can increase the healthcare associated savings, which equates to almost 7,000 new nurses for the NHS. And this is also just a summary from NHS England. Last year, this cardiac transformation program was announced, and you can see the top priorities for this financial year, included the perfection of optimal management for restrictions using lipid-lowering targets and therapies, and this is what we're going to be focusing on today. You can see this, there's a lot of talks around cardiovascular prevention to include lipid optimization, and there's a lot of figures have been collected in nationally with this quality improvement data from CVD Prevent. And I tried to show here that the improvements in the in this cardiovascular lipid lowering metrics since September 22 until now, you see that for the CVD-009 cholesterol, which is the indicator of patients with GP recorded CVD, and the lipid lowering therapy was 79% 2 years ago, and now it's increased to 83.7 in Southwest London. And this new indicator called CVD-007, which kind of matches with what is on the quality improvement, quality outcome framework for primary care as well. Before it was 28.4%, and we are steadily increasing this percentage to 37.3% as of March 2024. And I added the link for the quality audit tool for if anyone is interested. So now I just wanted to go through some lipid lowering therapies. Maybe you have attended other webinars and you've already seen some of the slides, but it's always good to recap on what the best treatment approaches that we have available in our area. This is just a schematic picture summarizing different types of lipid lowering therapies and their mechanism of action. We can see that there is decreased synthesis in the liver can be achieved by use of statins, and more newly available, you have as well bempedoic acid, which we're going to be talking about a little bit later on. We have the injectable therapies which act on the liver protein called PCSK9, and those are monoclonal antibodies called alidocimab and evolocumab, and more available now in the NHS. We have inclisiran, which is another therapy that can be prescribed currently in South of London by hospital teams. And also we have other therapies that I'm not going to go much into detail, but you see ezetimibe is another option to reduce absorption of cholesterol in the gut. You probably have seen this table many times, but it's always good to emphasize the importance of knowing roughly your LDL reduction.
Go ahead, if you don't mind. I'll make it a bit quieter.
Sorry? Can I help anyone?
Can you mute yourself, please?
Okay. I'll continue.
Pedro, sorry to interrupt. People are saying there's quite an echo.
Yeah, it's because someone is not on mute. I don't have microphones today. Previously, people complained of when you are using microphones. So today, if anyone can mute themselves, that'll be great.
Thank you.
All right. So yeah. So this this table is very useful to kind of summarize the different types of statins available and the combination of bempedoic acid and ezetimibe and the specific LDL reduction that you can achieve with each of these statin therapies. I can see I normally suggest to always look at the atorvastatin and the rosuvastatin column and the doses, because as you can see from atorvastatin 20 and 40 and up to 80, they as you double the dose of statin, they would increase of LDL lowering effects only by 6%. So sometimes, depending on the patient case and strategy you're using, either primary prevention or secondary prevention, it might be worth considering a combination of statin and ezetimibe instead to achieve greater LDL reduction targets. And this slide I've taken from ECL Partners. They have a very comprehensive ECL practice frameworks on cholesterol and other disease states. And you can see here it's very useful to know this this pathway when you're dealing with patients with statin intolerance or patients complaining of muscle symptoms. There are other conditions that can cause muscle symptoms, and it's always very important to rule out or to ask patients about other factors that may influence this type of symptoms. So as you see here, sometimes it is useful to measure CK if patients complaining of pain, tenderness, or weakness, and rule out other possible causes such as peripheral artery disease, patients with vitamin deficiencies, patients with infection or trauma, and patients with alcohol addiction. And based on this and the CK levels, you'll be able to make an assessment of what your next step would be. But based on normal terms, I would say if the patient complains of muscle pain and aches with statin after being on the statin for a few weeks, if the CK level is raised, it's useful to stop the statin, have a statin holiday for 2 to 4 weeks, or even up to 6 weeks, depending on the severity of the symptoms. And then slowly reintroduce at a lower dose, and this can be uptitrate as tolerated. And when you're dealing with statin-associated muscle symptoms, it's always useful to consider other types of statins as well, because the tolerance depends on specific patient characteristics and age and other factors. And what a statin might not work for one patient, it would work for another. And for example, atorvastatin and rosuvastatin, the molecule is slightly different. So rosuvastatin is more hydrophilic and atorvastatin is more hydrophobic. So by changing the statin, you might see that the side effects subside. And these are the key points from the ECL Partners. You always consider food and drug interactions when making decisions about statin doses and statin durations. Look at adverse events as a possible risk, but the adverse events attributed to statins are no more common than placebo. Stopping statins is associated with increased risk of major cardiovascular events as per clinical trial data, and is important for primary care, especially not to label patients as statin intolerance without a structured assessment. I would say statin intolerance really is for patients who tried at least 3 statins at different doses and at different times throughout a few years, a couple of years, or 2 to 5 years, for example. Then that you can consider statin intolerance. But if the patient's only tried 1 statin at 1 particular dose, I'd suggest to kind of investigate a bit further. It normally could be dose-dependent side effects as well. And the most important thing about these key points is that a statin at any dose reduces cardiovascular risk. So if the patient is not able to tolerate a higher dose, it's always good to include the patient in the shared decision making and discuss like the most appropriate dose for a particular patient. And if the CETAs require a lower dose, you can always consider alternative treatments like other statins or ezetimibe on its own, or the combination of ezetimibe and bempedoic acid, which is called Nustendi. And this is the summary I've had for this drug. Is a nice GA693, and he acts on the production cholesterol synthesis as well by a different enzyme in the ACL enzyme, which leads to decreased cholesterol synthesis, and is a prodrug and should be converted by coenzyme A in the liver to be active. So this conversion does not happen in the skeletal muscle. So in theory, this drug should be less. There should be less association with the muscle symptoms than statins. However, there are still patients that normally will have side effects with this drug. The beauty of this drug is also because it can be used in primary and secondary prevention, and it's normally well tolerated. However, I would say with a caveat that I normally would try other types of statins before giving the patient this option, because this is slightly more expensive and requires more baseline blood tests. And there is although there is new data from the CLEAR outcome trials that was published in 2023, showing cardiovascular outcome and safety data with bempedoic acid, conducted as a randomized controlled trial involving almost 14,000 people. The LDL reduction that you see with bempedoic acid alone, it was around 28%, and with ezetimibe about 38%. So compared with statins, the reduction is lower. And the main thing to report is that there is a small increase of gout and anemia with this drug. So it's useful to, if you are going to offer this as a therapy option for your patient, please make sure that they are aware that there is a small risk of gout and anemia. I would say as a baseline, you should order full blood count, liver function, urinase, and a urate level. Normally I would assess for the risk of myopathy and gout as well. And for patients who have history of gout, I wouldn't advise this drug because there will be increased risk of developing gout and poor outcomes in those cases. And then the follow-up is normally done with a repeat lipid profile, liver function and urate, and assess for the gout symptoms. Sometimes you can have an increased risk of increased levels of urate not associated with gout, and in those cases, it's okay to continue the drug. And currently, we have this combination drug available for primary and secondary care. And in primary care, this drug is number one, which means that it needs to be recommended by a specialist, either from through clinical letters, or it could be from advising guidance as well. And that is available in through most common trusts in South West London. I think St George's, Croydon, and Epsom and Helier offer this service through ERS. Any questions so far from anyone? I can't see anything in the chat, so I'll just carry on.
No questions.
Okay. And then I thought I would just give this, just add this to the slide as well, from these health pointers on how to manage abnormal liver function for patients being started on statins. And my rule of thumb is if the ALT levels as baseline is above 100, I would wait before starting the statin in those cases. However, GGT sometimes can be elevated after infection or antibiotics. So we do not normally use GGT to assess whether the patient can be started on a statin. It does not normally affect GGT. It mainly affects ALT. Once you get ALT and baseline was above 100, and then you repeat and it's coming down, you can once it's below 100, you can consider the introduction of the statin at a lower dose, depending on the strategy, whether it's primary or secondary prevention. If it's secondary prevention, I'll normally try starting at a torvastatin 20, for example, because the LDL reduction is considered considerable at that dose, and then titrate it as we go along. And for rosuvastatin as well, it can affect liver function, but also it's important to check for the renal function as well, because depending on the renal function, there is a maximum tolerated or advisable dose for rosuvastatin. And consider also other causes of abnormal liver function, and the most common causes we see in practice is alcohol, fatty liver, hepatitis, or recent infections as well. Sometimes it can increase infections, or antibiotic use can also increase your LFTs. Normally, that will also increase the GGT if it's alcohol or infection or antibiotic related. And most adults with fatty livers are likely to benefit from statins because they normally have fatty liver because of a variety of risk factors, including lifestyle, diet, and prolonged hypercholesterolemia. So they'll benefit from it, although it probably should be used with caution, with a lower dose to start with. And I just added this here, just this is a little summary from one of the doctors that provide Medscape guidelines, called Kevin Fernando, and he released this guidance this week, and it just has quite a lot of useful information on how to interpret it and deal with liver blood test or liver abnormalities. As you can see, I don't know, it's quite small. I won't go in a lot of details, but it's just to highlight that there's quite a lot of useful guidance for you to use in your clinical practice. And as you can see on the number,
do you think I should be dating other people? Do you think it's wrong for me to date other people right now? Okay, right.
Hello, can you mute yourself, please? So as you can see, from pharmacological causes, there's quite a lot of prescribed drugs in primary care can cause hepatotoxicity, and they varies from paracetamol to antibiotics, or to other drugs like amiodarone, colchicine, and other DMRs used for rheumatoid arthritis. The other thing I would say for some common drug interactions is the use of amiodarone and statin, use of colchicine and statin, and use of anticonvulsant statins as well. So it's very useful to kind of like check for drug interactions and Stockley's and Medicines Complete, or any other relevant guidance that you have in your practice. to assess on the best doses and dose adjustments required for specific patients. So now I'm just going to go through quickly on the PCSK9 inhibitor therapies that I've mentioned before. It acts on the PCSK9 protein. This PCSK9 protein is responsible to break down the LDL receptors, which in turn can increase the LDL cholesterol levels. And this therapy targets the PCSK9 protein by inhibiting them in the cell surface. So the monoclonal antibody kind of binds to the PCSK9 protein, and that will prevent the PCSK9 protein from degrading the LDL receptor. That improves the LDL receptor in the cell surface, and therefore it reduces the cholesterol, the cholesterol in the blood circulation. There are two types of monoclonal antibodies, and they have had extensive data associated with them in the last 7 to 10 years. There have been major outcome studies in secondary prevention on top of statins, and for these therapies, we had a number needed to treat over 2.5 of 65. In these major cardiovascular outcome trials, there was approximately 150 major cardiovascular events avoided by using this therapy. This therapy is, for primary care, is important to know the NICE eligibility criteria, because you might find that with your current cholesterol indicators, you'll be able to identify patients who may benefit from these therapies, and you can refer them to their local lipid clinic for assessment and initiation of these therapies. Currently, all of these monoclonal antibody therapies are hospital only, so it needs to be done. It needs to be done by a lipid clinic, and the patient can inject themselves every 2 weeks. Inclisiran is another injectable therapy. It has a nice TA from 2021, and it blocks the PCSK9 protein as well, but it blocks the production of it at the source via inhibiting the silencing RNA. And therefore, the PCSK9 protein won't be produced, which results in increased LDL receptor in the liver surface. It can be used only for cardiovascular secondary prevention for patients who have LDL above 2.6 and are already on the maximum tolerated statin or ezetimibe, or for those patients who have who cannot have statins and are already on maximum tolerated lower therapy. And the benefits of it is LDL lowering effect of roughly 50%. It has no drug interactions and very well tolerated with only just mild to moderate injection site reactions. We currently do the therapy from lipid clinic at St. George's Hospital and Epsom St. Heliers only. We have roughly at St. George's roughly 50 to 60 patients, and it's been quite well tolerated. The limitation of this drug is that we're still waiting for cardiovascular outcome data, which is due to report in 2026. We have enough safety data to warrant the use of this drug. As you know, by reducing LDL, you reduce cardiovascular risk. However, there is currently formulary issues with inclisiran. Currently, it's hospital only. Other parts of the UK, these drugs can be used in primary and secondary care. We're hoping to apply for a formulary application in the next few months. So I'm just gonna. So this is just a table to summarize the eligibility criteria for both drugs. Might be very useful for you when you're doing your medicines optimization project, so in primary care. So if you have any patients who meet this criteria, please send them or refer them to our lipid clinic. And we have also this new oral medication, which is purified form of fish oil, which is also got an ICA, and is normally used for patients high risk of for second prevention patients a high risk of another event, who are already on statins and have a high LDL with a high triglyceride levels. However, normally I would advise we exclude other causes of high triglycerides before starting this medicine. Often we see that the main common cause of high triglycerides are diabetes and alcohol excess, and by addressing those factors, we normally can address the triglycerides. However, for specific patients who are very well optimized already and triglyceride is still above 1.7, that can be started through lipid clinic as well. From the reduced trial, there was a significant reduction in the primary composite of cardiovascular outcome, MI, death, stroke, and coronary revascularization with this therapy. As I mentioned, the size increases incidence of AF and flutter. So the person, the clinician starting this should weigh the benefits and risks before starting this medicine. Currently in South London, the medication is AMBER 2, which means can be done in primary care after stabilization from secondary care. So normally we give and then can be continued in secondary care. So any questions so far? I'm just going through a few case studies now. If anyone wants me to go through anything, that'll be a good time to do it. Sorry?
No questions yet. I do have a question, but I'll leave it till the end, if that's okay.
Okay, sure. So I've got a case study then. So a few case studies. So I've got a 65-year-old male who was referred to us for optimization. He's got a history of previous stroke and other cardiology issues, and including high cholesterol, high blood pressure, chronic kidney disease, and GORD. Please mute yourselves. I can hear some background noise. So he's a non-smoker and drinks minimal alcohol per week. He's obese and has a history of different multiple statin intolerance, including atorvastatin, rosuvastatin, pravastatin, which all cause myalgia. And this patient was seen in our clinic many times. Initially, we noticed in 2021 his cholesterol levels was total cholesterol was 0.9, LDL was 2.4, and HDL was normal, eGFR was 50, and slightly raised urate. The patient was started on the therapy, bempedoic acid and ezetimibe. However, as you can see here, what the next steps in this therapy for this patient, we have three options. We have the bempedoic acid in addition to the ezetimibe. We can offer injectable therapy, or we can also offer a low dose of rosuvastatin once a week, for example, because he's got quite a long history of statin intolerance. So he was offered bempedoic acid and ezetimibe because at that time inclisiran therapy was not available. He was offered that, asked to review his blood tests in 3 months, and we were aiming for LDL less than 1.8 for second prevention. And we also offered a repeat renal function due to previous CKD, and we offered weight management program in the community. And I can just I just dropped this slide here just to highlight that that it's very important to focus on high blood pressure for patients with comorbidities, because it's associated with a lot of hypertension mediated or target organ damage, and you can see that this patient has high history of long history of hypercholesterol and CKD as part of a poorly controlled high blood pressure. When he attended the clinic, his blood pressure was high. So you can see this slide from the ASC hypertension guideline is very useful. If you haven't seen it, I highly advise it. It's a very comprehensive guideline. But when we followed him up, his bempedoic acid had to be stopped because he developed 3 episodes of gout. The gout was associated with high uric acid, and therefore we had to stop this medication. So now we only have 2 options available. We had the injectable therapy and rosuvastatin, because he had already tried almost all of the other therapies available. We could also just give him just ezetimibe on its own, but that the ezetimibe on its own is roughly 22% LDL reduction. So again, this wouldn't be sufficient to bring him to second prevention targets. So this is just a slide to summarize the eligibility criteria. His LDL is about 2.6, so he will benefit from inclisiran. So he was started in inclisiran, and he's now on the under our clinic for continuing of inclisiran injection therapies. However, in other lipid clinic appointments, we noticed that his blood pressure has been under controlled, and HbA1c and liver function also deranged. His pre-diabetes and his liver function is slightly raised. So we offered him to optimize his blood pressure with increased condensate to 24 milligrams daily. I've given him comprehensive advice on diet and lifestyle to aid loss, because I had a suspicion that this patient had some degree of fatty liver as well, and I've been monitoring him with repeat every time he comes to the clinic. His liver function is kind of stable, but if this continues to rise, it will be useful to refer to our hepatologist colleagues for perhaps a ultrasound. And I noticed that he's got CKD. He might be useful to start on SWL2 inhibitor. However, he was not keen on starting that therapy yet. So hopefully, with further discussions, we'll be able to kind of safely offer this therapy in the next appointment. And then again, just monitor all the other risk factors he's got. So, there's quite a lot of things going on for this patient. But from an LDL, from a cholesterol point of view, he's meeting targets now with an LDL less than 1.4. So now I just wanted to go through familial hypercholesterolemia. I'm not sure how aware you are with familial hypercholesterolemia, but I was just gonna summarize the main things about it. So the familial hypercholesterolemia is a genetic disorder affecting a lot of 1 in 250 people in the UK, and is an autosomal dominant trait, which means that people have FH can pass on to their generations. and there's a 50% chance of the tutor having FH as well. It's called FH is caused by normally mutations or pathogenic variants in proteins associated with cholesterol metabolism, and it's normally the most common is the mutation in the LDL receptor, which prevents the cholesterol from being broken down effectively. So those patients have a high LDL burden over years, and it's important to kind of screen for these patients in primary care, because the earlier we identify those patients in primary care, the earlier they can be treated to prevent progression of coronary atherosclerosis. And by if these patients are left untreated, 50% of the men will have a myocardial infarction by the age of 50, and 30% of women will have a MI by the age of 60. So it's crucial to identify those patients timely in primary care, and the main thing is to start them on therapy if you suspect them. You suspect they have FH, start them on therapy and refer them to lipid clinic for genetic testing or cascade testing of their family members as well. And I can also, from the hypertension guideline I mentioned just a moment ago, now I can see that familial hypercholesterolemia is being now added to the hypertension guideline, and is considered now a high risk category, as almost the same kind of like risk as diabetes in CKD patients. So from primary care point of view, it's important to know the criteria for FH screening and how to identify those patients in primary care. So the most important thing to know is that Simon-Brewer criteria is what is nicely recommended for diagnostic criteria, and normally if patients have total cholesterol above 7.5 or LDL above 4.9, plus family history, which is very important to ask patients, and then patients might be a pro-FH, and they'll benefit from a lipid clinic referral. If you find patients who have a stigmata of cardiovascular disease, including tenders stomata, or a previous mutation, genetic testing, so those patients are confirmed FH and they should be treated as per the guidelines. So the our key takeaway here is that if you suspect them, if you suspect they have FH, start treatment with high intensity statin as soon as possible, and then refer them to the lipid clinic. And then once diagnosis is made, then we'll be able to kind of screen all the family members as well for the same condition. Probably I'll just go through this slide with you. I'm not sure if you can, probably it's not going to work because it's not on the presentation mode. Oh yeah, so this is just an overview of the mechanism of PCSK9 protein. So there is LDL receptors in the liver surface. So the LDL cholesterol is removed by this pathway, the LDL receptor pathway. So those proteins I mentioned before, called PCSK9, they go to the cell surface and degrade the LDL receptor. So by preventing the recycling of this LDL receptor, it means that there is less uptake of cholesterol from the bloodstream, which it causes high cholesterol. If you target the PCSK9 protein, as I mentioned before, with the inhibitors, the PCSK9 inhibitors, it means that there's more LDL receptor in the liver, and therefore there's low LDL cholesterol in the bloodstream. So I've got another case study, which is another patient from my clinic, seen last year after having been admitted to hospital with a query stroke. And one of my colleagues, pharmacist, has advised he will be seen in our clinic. So he's got a history of high cholesterol. He's got a history of previous statin intolerance, which are quite severe. It causes rhabdomyolysis with very, very high CK. Actually, when he was discharged from secondary care, he was seen to have had possibly a migraine or aura rather than having a stroke, and this was excluded with an MRI. However, I noticed on screening this patient history, he also had high blood pressure that was not treated, history of myocarditis and IBS, CTCA from September, as St. Haley showed no significant coronary artery calcification or stenosis. So I've taken a comparative family history from him. He's got quite a lot of family members with previous MI and bypass graft surgery, early age, less than 50. Lots of family members have high cholesterol. 2 aunts have high cholesterol, and they're on statin therapy. 2 of his sisters also have high cholesterol and on statin. Apparently, his father said to him that he had high cholesterol, perhaps query for FH, but this was never inquired through lipid clinic to confirm via genetic test. So this patient has 4 children, a 2-year-old female and 3 boys. And at the lipid clinic, he was not on any medications. So you can see his blood cholesterol was very high. It was 10.4, when LDL 7.6, and he had other risk factors as well, including high alcohol intake, over 40 units per week, and his BMI was 32, and blood pressure is slightly raised. So because of this previous statin intolerance and rhabdomyolysis, I was not keen on trying a statin for this patient. So I advised him on lifestyle changes, mainly reducing mainly reducing alcohol intake, and I advised him on trying ezetimibe because he's a primary prevention patient, and although he has history of IBS, so it is useful to take into consideration when offering ezetimibe, because that can cause GI disturbances, could be bloating, constipation, or diarrhea. And because he meets the Simon-Broom criteria, as I mentioned before, he was offered a genetic test to rule out FH. So the options are, if the FH is confirmed, then as per NICE criteria, he can be offered a PCSK9 inhibitor. For primary prevention, the targets are slightly different. The LDL should be above 5 despite lipid lower therapy to be able to be offered PCSK9 inhibitor initiation. And we offer also family screening for all children above 5 by the local lipid clinic. And I asked him to monitor his blood pressure, and because he's quite a young guy, I think mostly it relates to high alcohol intake, but it's important to take into consideration when doing cardiovascular risk management for this patient. So in April this year, I saw him again. He had his genetic report confirmed FH. With an LDL receptor mutation. That was kind of like shocking for him, because he was quite young, and although he kind of had quite a strong family history, he probably wasn't quite ready for that diagnosis. So we provided very, very long genetic counseling kind of sessions and psychological support. He was offered follow-up clinic with a consultant as well, and at that point we started him on evolocumab, which is one of the PCSK9 inhibitors. And recently we've repeated his blood cholesterol, and his cholesterol is coming down, however, still raised. He told me that he had stopped his ezetimibe because he had changed his GP and there were supply issues. So it's quite important to kind of check those things, especially for patients who might have a risk of adherence and non-adherence. Sorry. Okay. So I think I've got a few more case studies, which I don't think we'll have enough time. So if I can just move on to just a couple of main points about the lipid clinic guidelines, if that's okay. Do I have about a few minutes?
Yes, please.
Yes, please. Yeah. So just to summarize the main points from the South London Lipid Guideline, which was approved in October last year. Just to note that the guideline was approved before the NICE CG 2236 was published in December. So the LDL target is slightly different. NICE recommended the LDL targets below 2 as a cost-effective measure for the secondary prevention cohort. However, the guideline also suggests that the lower the LDL, the better in most cases. So from the guideline, the most important points to note is that now we recommend the key risk 3 as assessment tool for primary prevention, and the threshold for statin use is now increased to up to 84 years. However, this risk tool shouldn't be used for patients with confirmed FH, CKD, or patients above 85. So the statin is normally recommended for those patients, and obviously this is in the guideline with more detail, but normally would advise atorvastatin primary prevention dose between 10 to 20. 20 is normally the first line, or rosuvastatin 10 milligrams as well as an option. However, it's also very important to consider benefit and risk and severity of specific patients, if you're doing this primary prevention strategy in primary care. And it can then titrate those if necessary to achieve the targets or consider ezetimibe. For NICE, they recommend a known HDL reduction of less than 40, but normally would advise an LDL less than 3 for primary prevention. For secondary prevention, you probably know all this by now, but it's just a summary that high intensity statins for secondary prevention is between 40 to 80, atorva or rosuvastatin 20 to 40. Reduce doses of statins if patients are intolerant of new side effects develop. Consider drug interactions, for example, clopidogrel and rosuvastatin, where rosuvastatin maximum dose will be 20. All can be increased, but normally in lipid clinic. It's important to also consider for patients with complicated statin intolerance that there are other ways of reintroducing statins, and normally I would advise a gradual increase of rosuvastatin, which is a long-acting statin, with a gradual regime of once a week for 2 to 4 weeks, then twice a week for 2 to 4 weeks, and then you can have a discussion with the patient to see what works for them. Depends on how high the cholesterol is and their medical history. And then, as I've mentioned before, we have Nustendi and ezetimibe also for second prevention. LDL targets less than 1.8 is what we should aim for. I think for your target is now less than 2. But for patients with multivessel disease, patients with previous more than one stent, patients with bypasses, patients with peripheral disease in addition to heart attacks, then those patients should have a low LDL, less than 1.4. And those patients will advise that you consider a lipid clinic referral for injectable therapies. And then for the high triglyceride pathway, the main treatment is still high-intensity statins. According to recent clinical trials, there's no fibrates were not associated with cardiovascular benefits, so shouldn't be prescribed on its own. And with the new guideline, we've prepared a quite comprehensive pathway on how to deal with high triglycerides, and this involves ruling out other factors, including secondary causing factors associated with secondary causes like diabetes, alcohol intake, patients with hypothyroidism, patients with other medications that increase high cholesterol and triglycerides, and tackle those first before moving on to the downwards pathway. But ideally, those patients with high triglycerides can be managed in primary care, apart from patients with severe high triglycerides. Those patients should be referred to lipid clinic urgently, as they are at risk of acute pancreatitis. This is another slide to summarize what we've talked about. Many different lipid-lowering therapies available for cardiovascular risk reduction and lipid optimization. And I'll just move on to move through a few slides. We've run out of time. This is just our recommended criteria for lipid clinic. As you can see, our aim is to kind of focus on primary prevention patients with that are query FH. So those patients are our priority, and for patients with secondary prevention who are already on other oral therapies and still not meeting targets, those patients should be they need to be managing secondary care, because we can offer them injectable therapies, as I mentioned before. And normally those patients are quite complex, and they normally are advised then to be managed for like they have a shared care between primary and secondary prevention. Normally they'll have loads of different diseases and medications. So important for primary care to kind of monitor those patients as much as workload allows. I'll just skip through this. Just information about our clinics, and just to summarize, the key take-home message here is by lipid optimization on its own is not effective. It's important to address all the cardiovascular risk factors, as we mentioned, including high cholesterol, obesity, alcohol, and smoking. Normally, we advise lipid profile obviously this lipid profile should be accompanied by other blood investigations if clinically indicated. HbA1c can give a good overview of how well diabetes or the sugar metabolism of that specific patient. Thyroid function before starting statins is quite important, and ruling out other secondary causes before starting statins is quite useful. I think I've gone through all those points already. I mentioned before there's quite different controversial points between different guidelines, between NICE, CSC, and other local pathways. However, all guidelines point to the direction of the lower the LDL, the better approach, according to a lot of large clinical trial data. Some people have asked me about bempedoic acid and ezetimibe, and I think, because number one, there's been a lot of queries on how to prescribe this medication in primary care. I would normally suggest to contact lipid clinic via advice and guidance, if you can, because we can just provide advice and you can prescribe it without having to refer the patient to lipid clinic. That's one That's one approach. However, more complex patients, it might be useful to just refer them through the normal lipid clinic referral pathways. And final point is, as I mentioned, for patients at high risk, including patients with FH, do not delay high-intensity statin. Please start these medications in primary care and then refer them to lipid clinic for genetic testing and further treatment options. Okay, some Heart UK references here for patient information, leaflets might be useful if you're interested. About cholesterol, to understand the cholesterol, about diet. So I just put all the QR codes there. And sorry for running over this presentation. If you have any questions, I'm happy to take it now.
Hi, Pedro. Sorry, I muted you as well. I think there's an echo when your mic is on. Excellent presentation as always. Very clear guidelines and pathways on choices, what to do and when to refer. Now, my question is on the complete opposite side of things. And I think also as pharmacists, when we're doing a polypharmacy review for an elderly who's in their 80s and they are struggling with dementia and they are on a statin for a cardiovascular incident that happened in their life once upon a time. And then we are at this junction of, do we keep on prescribing or do we stop the prescription? And you know, especially when there's a capacity issue and we're trying to reduce the pill burden for the patients. What are your reviews on that, Pedro?
So yeah, that is it's a tricky question because that will depend on the life expectancy of the patient, their quality of life, and previous medical history. Because you know some older patients might have like a life expectancy of over 5 years. So you might want to kind of continue those patients with the statin. If the patient doesn't have any intolerances or the other side effects. Other option is you can reduce the dose as well, or you can even reduce the frequency if they have controlled cholesterol levels. But if you know, it is tricky. It depends on whether they've had previous heart attacks or strokes, or they are high risk of another heart attack or stroke as well. If they had recent cardiovascular events, they are higher risk of having another event, especially in the first year. So the answer is it really depends on the patient's history, life expectancy, and also their opinion as well. Because some people might not want to stop the medication because they might feel that they have a risk of having a heart attack. Other patients might just be happy to stop it, and this is a shared decision that we need to have with patients.
Well, thank you very much, Pedro, for an excellent presentation. Anybody else has any questions, please write it in the chat, raise hands, just so we can ask Pedro before he has to go for his clinic. We're okay to share your slides, Pedro.
Yeah. I'll send the slides over. Yeah, sure. I have prepared more case studies, but you know, there's quite a lot of information to go through, so I'm not sure if yeah, next time I'll try to reduce down the slides to focus on more case studies. I think it's useful. Any questions on the lipid community referral for secondary prevention, on injectable therapies? Anything that you might want me to clarify that could be quite useful for your practice? You know, there's quite a lot of patients not meeting targets, as I mentioned, as I showed in one of the slides. And I know there's quite a lot of different teams in primary care that are focusing on these cholesterol targets. So I'd be happy to kind of go through anything again. Do we have targets for primary prevention for others? Yeah. In this last one of the last slides, I mentioned that anomaly for primary prevention LDL less than 3. That's just a general advice from the guideline. If I dig deeper into the this kind of LDL targets based on ESC, that might confuse you a little bit, because that would depend on the other risk factors. But just in general, less than 3 primary prevention. It's on the guideline as well. I think if I go back one slide, yeah, it's on this table here. Primary prevention, second prevention, and familial hypercholesterolemia. I added the targets there for both NICE and ESC. And for FH patients, there are primary prevention or second prevention. Those patients need to be treated aggressively. Any other questions? Sorry, there's a lot of information on the slides. If you have any questions after this webinar, feel free to contact me. I'll add my email on the last slide as well.
Thank you, Pedro.
All right. Thank you very much, everyone. Thanks for listening.
Thank you, Pedro.
I'm just going to stop sharing now.
Hello.
Have a good day, everyone. Thank you very much.
Bye. Hello, shall we do our Menti?
Yes, please.
Okay.
So I think Pedro had maybe an issue with the mic because everybody's having an echo when we try to speak. But yes, please share the Menti. Thank you, everybody, for joining and listening to a very useful lipid management presentation by Pedro. So please, you can see the Menti on screen. Nisha is going to be controlling it today. Chadney's not in today. The code is at the top of the screen. Please join in. Just give us some hearts so we know that you have logged on. If you can, please join in. It just helps us assess how useful the presentation has been for you today, and if there's any changes or modifications that we can do. This is the QR code that you can also scan that will take you to the Menti instead of the code. Shall we put a timer, Nisha, please?
Yeah, I'm not as
savvy with this. Okay.
Yeah, as Chani is.
Okay. If you can let us know which borough you're from, just to help us understand the distribution of pharmacists within the different boroughs. Thank you. And how did you find the update and discussion on lipids? If you can choose one of the answers, that'd be great, so we understand for next time and we can tailor the type of information that you need. So some of you said it's too much information, just right, or need further sessions on the topics. It is a heavy topic. I agree with a lot of things covered with a different kind of like lipid management. But I think we need to understand when we know what our targets are for our patients, what are the options out there, that would help a little bit. We might ask Pedro to do another session for us, but to focus on one medication group rather than all of them, so we can have more case studies.
Okay, Hala, the next slide is feedback to your section. So I'm going to stop sharing and then you can start your protocol bit.
So we're moving on to the next one. This one. Just bear with me 2 seconds. Okay, can you see my screen?
Yeah, but it's not in presentation mode.
Okay, now?
Not yet. I saw that you clicked the icon, so it should be on soon.
No, it is on a presentation mode now. Okay, no?
Not
Okay,
for
let me try
me.
to, okay, 1 second, let me just do something, stop sharing first. Put it on slide mode. I don't think it's gonna work for some reason. So let's share. And then, all right, just because of the time, I'm aware of the time. Let's try it now. Any luck?
No, Hella. They're still in slide form.
Okay, I can't change it because I only have one screen, so I won't be able to change it.
Do you want
Hopefully
me
when
to
we share the
try?
slide. Okay, please do. I'll stop sharing from my side.
Okay.
So my presentation is about protocols, and I think as pharmacists we are asked to write protocols every now and then. So okay, thank you, Nisha. This is not a very detailed kind of like giving you 1, 2, 3 on how to write a protocol, but it's the concept of writing a protocol. What does it implement? What does it have? Why do we need to do it? So protocols are considered as a part of a quality improvement project. And the aim is to make difference to patients by improving safety, effectiveness, and experience of care. And that's by understanding our complex healthcare environment, applying a systemic approach, designing, testing, and implementing changes using real-time measurements of improvement. It is a chance for us as pharmacists or as a team within the primary care to improve care for our patients, show leadership skills, improve our presentation and time management skills. It is an opportunity to address issues that we are facing within the practice, whether it is a process, an operation, a service, a system. Whatever we're trying to write the protocol, it could be writing a protocol about how to do your repeat dispensing, or writing a protocol for your prescribing team on how to deal with high risk medication. So there's variable things that we can use the protocols for. Next slide, please, Nisha. So there are different types of written quality improvement pieces that we need to understand the difference between. The first one is a protocol. And what we mean by a protocol is an agreed framework outlining the care that we provide to our patients in a specific area of the practice. As I said, whether that's operational, whether that's prescribing, whether that's a service. They do not describe how a procedure is performed, but why, where, when, and by whom the care is given. A standard is a different type, and that's a statement reached through consensus, which clearly identifies the desired outcome. And it's usually used within an audit. So you have a standard, and then you do the audit and you compare it to that standard. A policy is a formal written statement detailing the particular actions to be taken in a particular situation. So normally you have prescribing policies, and having a prescribing policy and then writing a protocol, they should kind of like cross with each other, but they're not identical. Guideline is a systemically derived statement that helps practitioners to make decisions about care in specific clinical circumstances, just like we have the NICE guidelines, where they have different statements and they have different standards, and all of these come together to give us a pathway to go back to understand how on the level of care that we need to give. Next slide, please. So what are the skills needed to write a protocol? The main thing, I think, having an enthusiasm and optimism and curiosity to make a change, even if it's not asked for you to do it, but for you to show that actually I have come across this, and I think writing a protocol will help the team, would help the clinician, would help the admin team or the reception to provide a better, safer service to the patients. That is the main thing where we reach for a quality improvement project. Relational skills also are vital, as it is a team activity. It's not a solo. If you're going to write something by yourself, it could be the best piece of work that you've ever done or even humanity have ever seen. But if the people around you are not receptive for this piece of work that you've done, then it is wasted, unfortunately. So it's important to be a big part of a team, to have that communication with your local practice, within your PCN, within a larger area as well. You need to understand how systems work. It's hard for anybody to give advice when you don't understand how things are working, whether within it is with your receptionist, with your prescribing team, with your clinicians. So it's really important that you have a good understanding of the systems and how to manage this complexity in another core skill that you need to do when you're writing a protocol. Next one, please. So as you work within a team and then you have the understanding of the issues that are going within the team, you need to reach the quality improvement is part of an education process for yourself and for the team. And what will you do to ensure that you yourself understand the problem that you're trying to resolve? So you understand that there's a problem, but you need to understand everything around the problem as well, whether that's the system, whether that's the medication, whether that is how to do the blood test, whether that involves any other education about mechanism of action of a specific drug. Once you do a blood test, you need to understand all of these things. So you need to have a full knowledge about the problem and the protocol that you're going to write for that specific issue. Also, how will you involve your colleagues and patients in your project, and how will they support you, and how can you support them as well? So, for example, if your supervisor reached out for you, please write us a protocol on the repeat dispensing. You might look at different references, but you don't know what the prescribing team are doing. So you really need to understand what's happening on the ground. If you are going to look at it as another outsider and you have a new pair of eyes and trying to understand where are the errors or where we can improve, and you look at another practice and you marry that into your own practice. So it's important to involve people around you to reach a best outcome. And you also need to have a systemic kind of like way to understand where is the start, where is the end, and what are the different steps that I need to do to make this protocol and to make this improvement sustainable and that everybody can understand and use them in the daily practice. Next step, please. The next slide, please. So as I said, the main thing to get started is to identify a problem. And although you are one person who look at probably the medication in a different perspective than everybody else within the practice, it's important to address this point from your point and from the other team members. So work as a team, don't work by yourself. Sit, make a small group, discuss this with your supervisor, discuss it with the people that are involved in the task that you're gonna write a protocol about. Use data to help with this. So for example, if you've done a clinical audit and you think there's an issue, bring that audit, discuss it with the team, tell them these are my findings, this is why I'm writing it down. Try to understand, even brainstorming with the other colleagues, trying to understand why is it happening and Can they see something different than you that would work? Because we each look at the problem from a different direction and a different angle. So it's important that you get all of that information and implement it in the protocol, because that would be the most effective protocol if everybody contributes to it. And it's empowering to everybody. It shows leadership as well. Next slide, please. So what are the advantages of using a protocol? Now, a protocol by itself is a framework of complex, specialized sequence of activities and events. It provides a better autonomy with a focus on how to do things and the shape of the work that we want. It also ensures that there's consensus between the team members. It provides legal protection and identifies training needs, may facilitate change as well. Next one, please. What are the disadvantages of a protocol? So sometimes people can find it like it is too rigid and suffocating and doesn't match every scenario or every patient care that we need. It also reduces the need for qualified staff because you will see, okay, I have a protocol. If everybody works on it, it doesn't mean, it means that I don't need somebody with a specific qualification. They only need to follow this protocol. It definitely needs regular reviews because things change. Compliance may be problematic for different people for different reasons. Can restrict clinical discretion as well. So for example, if I have written an asthma protocol and I gave it to the healthcare assistant and to the nurses, and they're following it to the bit, that might make them feel, okay, I don't need to make my own clinical decision anymore. I'm just following it one by one. And I think as pharmacists who come from the background of SOP, sometimes we feel these could be restrictive. And when we moved to primary care, we did not have that SOP in our work. So we felt like actually we might be given too much clinical freedom to make decisions. So protocols, again, might have that kind of like feeling to some staff where it feels that it affects and restricts their clinical judgment. Next one, please. So what constitutes a good protocol? It has to be clear. It has to have accountability. Who does what and when do they do? When do they refer? When do they come and ask? It should be very clear in the protocol. It has to have a specific referral criteria. It has to be clear. It has to be brief and fit with professional guidelines. So, to be honest, this is the end of my presentation. I just wanted to give you two completely different protocols that I had to write recently. The first one was for a protocol for asthma reviews, and I wanted to stratify different asthma patients to reduce workload. As once upon a time, I was the only one who was doing it in the practice, and we had quite a lot, and my time restraints didn't help me to meet all of those patients. So what I did is I wrote a protocol where I stratified patients into different groups. Those who are well controlled, those who are intermediate controlled, and those are not well controlled at all. So that depended a lot on their ACT score. And then through the different scores, I had to make each one, what do I expect to do next? So for example, well controlled, I'll look at their ACT score. Any of them, if they answered 3 or less in any of the questions, then they need to have a review over the phone or face to face. If they were fine, nothing is scored under 3, then I can do a remote screening, check their inhaler, check that there's no issues, no antibiotics, no steroids was issued. Then I'm happy to do a remote clinical assessment without talking to the patient and just fill in the asthma review. If they were within the amber, which is between 19 and 15, then those will need a telephone consultation. And if they were in the red or overusing SABA, or they had a steroid or a hospital admission, again, these will need to have a face-to-face review. Another protocol that I had to write, and I had to write it within 24 hours, we had a serious incident regarding warfarin for our patients. And although we had warfarin within our dispensing and prescribing policy, we didn't have a specific protocol for the warfarin. So I had to write a protocol for the practice to ensure the safe prescribing. And that involved all different members, which were the dispensing team, the prescribing team, all the clinicians. If we had warfarin clinics, we need to get them involved to see what they're doing. The prescription clerks as well, if they receive a prescription and they send it to the doctors, what do they need to do ahead of sending it to the doctors? And then we had a meeting, we discussed everything, we discussed where the error happened, we discussed what we can do differently, took all ideas on board, wrote the protocol, send it back again, have a meeting, discussed it, put in practice, and then we will review it again in 6 months' time. So these are kind of like completely two different protocols. Each one came into practice for a completely different reason, and they were initiated from a different angle. One to reduce workload, and the other one is reduce risk and to improve safety. So this is where I'm trying to say, where you take leadership and you write a protocol, you need to have an aim, a purpose, and you need to understand who is it serving and how can you implement it and who will you get on board with it. Any questions? Has anybody written any protocol for their practices? Do you want to share the last mentee, Nisha?
Yeah, I will just share my screen. Okay, can you see it?
Yes.
Okay.
So for those who are remaining in the, if you can just let us know. If you think it's too much information, too little information, just right, need further sessions. Just so we know how, if there's a template, there's no template for writing protocol, unfortunately. As I said, it's completely different. So it might be worth probably doing a small session on the face-to-face at some point where we can see how else we can address writing a protocol. I'm more than happy to take emails from anybody who's trying to write a protocol and they're a bit stuck. Let me know. Drop me an email. My email is always there. And yeah, I can help you discuss it and see what are the points that you're trying to do. So the last bit of the mentee, if you're reflecting on today's presentations, how do you feel about supporting patients with the clinical area covered today, which is lipid management? How do you feel about prescribing statin in primary and secondary prevention, how to deal with their side effects, and changing the dose or when to refer? Have you opened the responses?
No, there aren't. I've got one now.
Okay, so this has helped the targets and alternatives to statins, absolutely. And I think from a POF target, even from a CQC perspective, we need to show that we are approaching our patients who are not compliant with their statins, understand why they're not taking it, and are we offering them any other options? This is one of the things I think that is high on the agenda, because if you saw the numbers that Pedro has shared, there is a massive change in the cholesterol levels and the cardiovascular risk reduction that has been shown since September 23 till March 24. So I think we all need to be on board on offering patients to understand when we do the medication review, if they're not using it, if they're having side effects, what can we do for them? When can we refer? And definitely try to bring those LDL levels lower, and the lower the better. Absolutely not be afraid of thinking of other solutions if patients refuse statins. Absolutely, because now there are other options that they can refer to a clinic. Need to keep going over the guidelines and consolidate knowledge to feel more confident. Absolutely, I think we do that day in and day out, even with the simplest thing. A little bit more confident, but still need to go through guidelines again. 100%. I think all of us need to go through the guidelines, and they are being updated quite regularly, and sometimes it's hard to keep up. Statin already doing side effects addressed, changing statins with GP input in full implementing. I am implementing. Not confident with referral, familiar cholesterol. I think that's absolutely fine. Not being confident in referring, but I think the younger patients who had a cardiovascular risk, who have high triglyceride and cholesterol, who have had it for a while, with a family history of cardiovascular disease, discuss it, make an audit, discuss it with your supervisor or with your leading GP, and take that to them and refer them to the lipid clinic. So this is an opportunity for a quality improvement project for you. Help to clarify what we can do if patients say they are getting side effects. Yes, 100%. I think this is the bad press with statin is a massive, massive thing, and trying to address these things. And I think for me, it's always going back to the lifestyle as well. In smoking cessation advice, reduce alcohol intake, having a healthy life. All of these things work hand in hand with medication. Medication at the end of the day is a supportive measure. It's not the only solution. We need to look at improving the healthy lifestyle for our patients and then encourage them with the medication as well. Next slide, please. So after this session, what would you want to implement differently in your practice, and how would you do that? You need to do to go forward. There's a lot of do's in that last sentence, Nisha. Yes, I think like depends on how confident you are with the statin. What are you doing for your cardiovascular risk patients, which is diabetic, stroke, cardiovascular? There's a large population out there who need to be on a statin. Are you just exceptionally reporting them? Are you having a discussion with each one of them? What is your procedure? What is your protocol within your practice that you're following to reduce that? What can you plan to move forward to improve the outcomes for your patients? Any suggestions that can help us all? I think from my perspective, I would run a certain audit onto patients with high cholesterol above 6 and triglyceride above 3, LDL above 3, and see, are they on a statin? Are they on ezetimibe? How's their compliance? I check the medication use. And then I will start to discuss it with my supervisor to see if we can have a cholesterol clinic within our practice to address those patients. And moving forward, do we refer them to secondary care? Do we try with a different type of a statin, a higher dose if they're tolerating it well? So it all depends on what kind of clinics you hold, and there's always, I think, a space for quality improvement. And this shows leadership from your sides where you are forward thinking. And I think this is the benefit of the Pharm as well. It opens up those conversations and discussions about what we can do after listening to a specific presentation? Okay, so the last bit is action. As part of a team, how do you think you can use your knowledge from today's session to enhance safety of prescribing in these clinical areas? What would you take back to your practice? What would you want to action from today's presentation? I think I need to bring Chadney back. You are very quiet with that, Chadney.
No responses, Hala.
I know, I can see that. Any action plan, anything that you guys would want to do? Okay, if there's no responses, I think this is the end of it. The next, when is the next one, Nisha?
Just bear with me, Hala. I will check.
Thank you.
So it's the 13th of November.
Okay.
And I think this is the one where we've swapped the topics a bit. So I will be sending out a comms. So we've swapped the February and November topics. So whatever was going to be in February will now be November and vice versa. So if you've registered, that's okay. It's just hopefully you'll still be interested in attending for that topic. And apologies, I've not sent the recording out for last month. I'm going to do today's and last month's together. So yeah, you will receive them.
Thank you, Nisha.
Thank you.
Thank you, everybody. I will see you next month.
Thank you.
Bye.